super excited to introduce today's final speaker, a mate from Down Under, who published a paper in 2020, and I think in the Journal of Physiology, and I think the night the paper was publicly released, I sent him an email, and the subject line was something like cool stuff or so. It took me 3 years and a little help to get him here, talking about Vaughan Macefield. Vaughan completed his undergraduate and graduate studies at the University of New South Wales. He then conducted his postdoctoral training in Sweden and the USA, including Yale. He started his first independent lab with Neuroscience Research Australia, and then later joined Western Sydney University as chair of Integrative Physiology. He's been the foundation chair of Integrative Physiology at the School of Medicine, Western Sydney University. He's been the foundation chair of physiology at Mohammed bin Rashid University in Dubai. And rumor has it that Cristiano Ronaldo is nowadays following his footsteps. He joined Baker Heart and Diabetes Institute, where he led the Human Anatomic Neurophysiology Lab. And nowadays, he leads the Human Neurophysiology Lab in the Department of Neuroscience at Monash in Melbourne. He's been the recipient of many prestigious fellowships from the National Health and Medical Research Council, including the C.J. Martin Fellowship, the R.D. Wright Fellowship, the Research Fellowship, and Senior Research Fellowship. Alongside his scientific career, he's been an important consultant on many technological developments in our field with various companies. He's published over 250 articles in prestigious journals and is also in the role as co-chief editor or editor of numerous journals, including Experimental Physiology and Clinical Autonomic Research. Most importantly, he's the most humble person, not only in this universe, but any other parallel universe. So without further ado, here it is for Vaughan Macefield.
Thank you very much, Julian, for the invitation to come here all the way from Australia. It was a very long flight. I got in late yesterday afternoon, so 24 hours travel, so I'm feeling really, really good.
Get some water.
And really, Matt, Ivan, I cannot compete with that. What I can do is a demonstration. I'm going to put my finger down my throat and vomit, but I won't actually. But has anyone asked, what does MANIAC stand for? I mean,
Mapping Autonomic Neural Interaction and Control.
Yeah, you made that up, right? Just to fit the word. But again, thank you so much for the invitation, and what a great day this has been. Okay, so without further ado, I'm just going to take you on a journey which will lead to the vagus nerve. Right. So most of the work I do involves a technique called micronography, which was developed in Sweden in the mid-60s by Karl-Erik Hagbarth and Åke Valbo, University Hospital in Uppsala. And it involves, so this is a participant's leg. It involves insertion of a tungsten microelectrode, in this case, into the common perineal nerve. We map out the course of the nerve by giving weak electrical stimulation around the fibular head, and we've just made these little marks there. And obviously the site that generates the biggest twitches of the muscles or generates the most intense paresthesia, pins and needles, from activating the nerve means that the nerve is closer to the surface there. So that's where we insert the microelectrode. We have this differential amplifier, which simply measures the potential difference between the electrode within the nerve and a reference electrode just under the skin. And we have a ground electrode on the other side. So this technique, as I said, was developed in Sweden in the mid-60s. It's been used to address various issues in neuroscience. You can insert it into the nerves that supply the hand to look at the tactile system, nerves supplying muscles to look at proprioceptors, look at the sympathetic nervous system. And as I said, you can put it in any accessible nerve. And so recently, I developed an approach of going into the posterior tibial nerve at the ankle, which is just here. And that allowed us to measure, for the first time, sensory endings in the sole of the foot and muscle spindles within the intrinsic muscles of the foot to work out how these receptors respond when you stand and when you're swaying. So important sensory signals that help us to remain upright. And there have been a few studies of the cranial nerves. So branches of the trigeminal nerve, the supraorbital, infraorbital. My colleague in Sweden, Mats Trulsson, he's a dentist. He actually took out my wisdom teeth. Oh my God, it was horrible. He said, he did it for free, which is pretty good. And did it under freaking local anesthetic. And it's like, you know the movie Braveheart, where they're ripping out his guts at the end? And he's very stoic. But he had some herbal medicine. I had nothing. Anyway, it was really awful. And as he took out, one set of teeth on one side, and he asked, and as I was leaving through the reception area, he asked me to smile so the other people didn't worry. But anyway, what he does as a dentist, so the nerve that you would put local anesthetic in to block it, put a microelectrode in there, and he could record from single sensory endings supplying individual teeth and work out their preferred directional sensitivity to forces, and they're exquisitely sensitive. He's also recorded from the lingual nerve, supplies the tongue, of course. And most recently, as you've heard, we've developed the approach of recording from the vagus nerve in the neck. But before I get onto that, let's look at, and the reason I'm showing you this is because it helps you to understand the sorts of nerve signals that we can record from. This is a cross-section of a peripheral nerve, okay, such as the common perineal nerve. All peripheral nerves, and cranial nerves for that matter, are composed of distinct fascicles. And within those fascicles, there are the large diameter myelinated axons and the small diameter unmyelinated axons. We can impale the myelin sheath of an individual myelinated axon, a large diameter myelinated axon, and in this case, it's a muscle spindle ending, a proprioceptive afferent, responding to stretch of the muscle. We can also get close to individual C fibers and record sympathetic axons. And note here that the myelinated axons generate positive going spikes, unmyelinated axons generate negative going spikes. This is important to know because it tells us that when we're in the vagus, we can work out whether the action potentials we're recording from originate in a myelinated axon or an unmyelinated axon. So, as I said, and we can get beautiful recordings. As you heard, I used to do nerve splitting in rabbits and cats and dogs. Okay, I don't do that anymore. But, split nerve fibers under microscopes and get big action potentials, and I thought I'd never see that again when I went to human work. But yeah, you can get massive action potentials. This is a tonically firing muscle spindle in the extensor hallucis longus muscle, the muscle that lifts up the big toe. And what it shows here is by pushing down on the big toe, so we've got passive plantar flexion, just pushing down on the toe, that stretches the muscle. And we can see this marked increase in firing rate with brisk stretch of the muscle or this slow stretch of the muscle, a slow increase in firing rate. And we can also, the great thing about doing human work is that you can ask the participant to perform a task. In this case, to voluntarily try and lift up their big toe. And we can engage fusor motor neurons, which are going to increase the firing of muscle spindles. But as I said, these myelinated axons generate positive going spikes. Sympathetic axons, C fibers, and we normally record multi-unit activity because they're tiny. They're a micron in diameter. So to get a microelectrode close to one of those is pretty tricky. So we usually record multi-unit activity, and as I said, these are all negative going spikes. Muscle vasoconstrictor neurons fire with a clear cardiac rhythmicity, as you can see here. It is possible to record from individual C fibers, both afferent and efferent, and basically with a very highly selective microelectrode, but this is all done manually. So you just have to get very, very close to the axon of interest. And just like all single unit recordings, you know you're recording from a single axon if all the spikes superimpose. And here we see the typical triphasic negative spike morphology of an unmyelinated axon. But to the matter at hand, can we record from the vagus nerve? So as we've heard, it's the longest and the largest cranial nerve, and it supplies structures in the neck, thorax, and abdomen. And it's also the only cranial nerve in which the vast majority of its territory lies outside the head. Now, you two up there chatting to each other, I'm going to send you out for being naughty, okay? Sorry, I'm just kidding. Chat away, chat away. Oh, they are. And like peripheral nerves, the vagus nerve is composed of a thick fibrous sheath surrounding the nerve, the epineurium, composed of distinct fascicles, each surrounded by a perineurium. And so really, it should be possible to record from these. And it's something that I've been wanting to do for years. Anyway, so in October 2019, which is 1 BC, you know, a year before COVID, put in an ethics application to do this, and surprisingly, it was approved. And this is through a major tertiary hospital, and basically presented the case, look, we routinely record from the median or ulnar nerve in the upper arm. Those nerves sit over the brachial artery, and the diameter of the brachial artery is pretty similar to the diameter of the carotid artery. He said, look, we've never impaled the brachial artery. So the carotid, you know, it's not going to be an issue. Anyway, I spoke to an anaesthetist at the Mayo Clinic, Tim Curry, who developed this ultrasound approach to micronography. So rather than electrically stimulate the approach that we use, they use ultrasound to guide the microelectrode into a peripheral nerve. And I said, yeah, I really want to record from the vagus nerve. Because, you know, we record from these nerves routinely, which, is, as I said, sit over the brachial artery. We've never impaled the artery. He says, well, you probably do it all the time. But the microelectrode has a diameter of 200 microns, electrolytically sharpened tip down to about 5 microns, 2 to 5 microns. So even if it impaled an artery and you withdraw it, it's going to self-seal, right? All the cardiologists, all the experts said, look, it's not going to be an issue. And it hasn't been an issue. But of course, it's something we want to avoid, the carotid artery. So, yes, as Julian mentioned, this lovely guy, Matteo Maria Ottaviani, I met in Pisa, and he was doing vagal recordings in the pig. And we spoke about, you know, wouldn't it be great to do this in the humans? I said, yeah, I've been wanting to do that. Anyway, I invited him to the lab in Melbourne, and we started doing this in early 2020. And as you know, after China, Italy was the country which was getting most cases. So he had to go back to Italy, and we had to stop all the studies. So this was just a pilot study, which we did on ourselves. It's amazing. I had people write to me saying, wow, isn't that great that you tried it on yourselves? I had other people saying, how could you justify doing that on yourselves? Crazy, right? But you need to try this on yourselves, and don't try this at home. Come here and do it. Anyway, so how do we do it? Well, as I said, we use ultrasound. We can image this is the internal carotid artery. So we're up quite high here, the internal jugular vein. And as we saw earlier, in Julian's presentation, the vagus nerve is just around here. And we can see the tip, we can see the microelectrode as it passes through the different layers of the neck. It's not uncomfortable. Actually, I was the first participant, and I knew we were getting close to the nerve because I started to get sensations referring to my ear and jaw and my shoulder. I'm not sure if this is going to work. Oh, it is going to work. Okay, here we can see, where is it? There. Okay. So this is the vagus nerve, and this is the carotid artery, internal jugular vein. The internal jugular vein is a bit flattened because we've got the ultrasound probe over it. But we can see, so basically we just have to choose the right angle. So we're going in and out, and getting the right trajectory, and trying to get it into this little baby here. There you go, in. And then when COVID all resolved, we could go back into the lab, and then we started doing a more serious investigation, recording from the right and left vagus nerves in 19 participants. And this delightful woman, Michaela Patros, this was her honors project, pretty ambitious. She's now doing a PhD with me, so fantastic work that she did. And so the sorts of signals that we record from are things like this. So here we have blood pressure, heart rate, ECG, respiration, and this is the root mean squared processed nerve signal. This is a multi-unit recording. We can see that there's this far field activity related to inspiration, which you can see here. But also, there are these individual spikes that come in, evidently with an increasing depth of inspiration, which is hard to see just with this respiratory belt transduced around the chest. But if we ask the participant to take a breath hold, maximally inflate the lungs, then what we see with this axon is a sustained discharge. Now, what could this be? Well, we have to basically identify things. We can't, rip open the chest and poke around. We have to use behavioral criteria. So we concluded that this axon was a sensory axon coming from the airways. It was a stretch receptor, like a pulmonary stretch receptor, because it didn't respond to humming, which would activate the laryngeal adductors. Because we know when you take a deep breath, you close the glottis to hold everything in. So it could have been that, but that if it was a laryngeal adductor neuron, a constrictor neuron, it would also respond during humming, which it didn't. And it didn't have this maintained discharge with an end expiratory apnea. We also find activity. This is now a multi-unit recording that is more active in expiration, or the second half of inspiration. And here there was a spontaneous swallow, and we get a large burst of activity. We conclude from this that this is indeed going to the laryngeal muscles, the constrictor muscles. We also find sites where we've got multi-unit activity related to inspiration, but also activity that is related to the ECG, so it's cardiac locked. And so we basically investigated this. These are two sites in two participants. I'll just take you through it. Time zero is the R wave. The black histogram shows the distribution in time of the next R waves of ECG, and the ones after that, and the ones after that, and then back in time. So the black histograms simply show the rhythmicity, the cardiac rhythmicity, as measured from the time intervals in the ECG. The gray histograms show the timing of the spikes from the vagus nerve. What you can clearly see is that there is cardiac modulation. The cardiac modulation was greater in this recording than in this recording because it was more tonic activity. Basically, and we can do the same with the respiration, okay? Basically, we catalogued all these neurons, these sites, and we showed, no surprises there, that respiratory modulation is much higher in the vagus nerve because the vagus nerve supplies a lot of respiratory tissues, lungs, airways, etc. But we do see significant cardiac modulation, and that's what we're particularly interested in. And it was that interest that led me to be invited last April to Croatia. Has anyone been to Croatia? It's a shithole, absolute shithole. I mean, look at this, pebbles. Admittedly, very nice blue sea. No, it's a beautiful place. I was very fortunate to be invited to Split, Željko Dužic's group. The reason being that they do all these amazing studies on these apnea divers, professional divers, free divers. They can hold their breath for over 10 minutes. So I was asked to go and do some recordings from the right vagus nerve just to see if there's anything magical in these people. We also did control participants. And I mentioned that, it's tolerated pretty well. Look, this is not aversive behavior at all. So if you actually have a microelectrode put in your neck, she was sobbing her eyes out before I put this in. And then she starts smiling. Isn't that great? No, I'm basically showing you this because it's tolerated very well and it's not painful and it's thoroughly humane. We have a microelectrode in here, and this is all the goo from the ultrasound. And here we have one of the breath hold divers and this is 5 minutes into the breath hold, but we've got the microelectrode in there. This was a 21-year-old guy. He'd shaved his chest before coming in. And look, he's holding his breath, right? So we can basically maintain these recordings. So when we put a microelectrode into any peripheral nerve, we often get a burst of impulses, mechanical irritation of axons. Of the loudspeaker, you hear this because you've just flicked the axons. You don't cut them, but this is a sure sign that you've entered the fascicle of the nerve. So I mentioned that these are all from the right vagus nerve, which, as you know, supplies the sinoatrial node. Could be a bit dangerous, right? If you're causing all these ectopic impulses, you could slow down the heart, stop the heart maybe, cause acute death or even chronic death. We had one, this was from a diver who's all fine, but then we're thinking, ooh, this is a bit strange. His heart's sort of going boom-bitty boom, boom. We're going to these long periods, asystole. And this is intriguing because this just happened, right? We've got this spontaneous activity, myelinated axons, positive going spikes. It's perhaps one could say this is a cardiac parasympathetic axon going to the right sinoatrial node. We don't know, because we can't rip open the chest. But anyway, there's this tonic firing and a large burst here, which perhaps is responsible for ultimately these changes here. Anyway, we asked this guy, can't remember his name, he's very tall, because he's from Croatia, they're very, very tall there, whether he was feeling okay, did we want to stop? And he was absolutely fine. So we continued recording from him, and his blood pressure slowly improved. Oops. And we recorded further sites in which we found these spontaneous bursts, which had clear cardiac rhythmicity. And this now is activity in C fibers, okay? In negative going spikes. So we wondered, what is this? Well, we showed that during slow, deep breathing, this activity became more concentrated towards the respiratory cycle, as you can see here. So we're thinking, well, you know, what happens during inspiration? Venous return increases, you get expansion of the right atria and the left, and so maybe this is a right atrial baroreceptor, a low pressure baroreceptor, responding to atrial filling. Anyway, it's early days yet, but this is what we're thinking here, that these could be stretch receptors in the right atrium. We also found sites, and this is really intriguing, where we see these very large spikes, which we get a spike, 2 spikes per cycle. And I'll show this on an expanded time base now. We have blood pressure recorded from the finger with a phenometer. We have ECG. And we have these 2 bursts occurring within the cardiac cycle. Now, I mentioned the blood pressure was recorded from the finger. So if we shift this signal back in time, it takes about 400 milliseconds to travel from the heart down to the finger. Shift this back in time, I think you'll be convinced that this first wave of activity corresponds to systole, and the second wave to the dicrotic notch, right? Take my word for it. I'm sticking with this. I'm not going to budge. So the question is, what could it be? Well, maybe this activity is related to the opening and closing of these valves. Again, it's all by inference because we can't open up the chest, unfortunately. We're now going through all our recordings and trying to extract single unit activity because that would give us a better clue as to whether it's afferent or efferent. So far we've got 31 recordings with cardiac rhythmicity, 10 from the left vagus and 21 from the right. And based on action potential polarity, we can conclude that 17 were defined as myelinated axons and 14 as unmyelinated axons. What sort of signals we recorded? Well, this is you can actually have this one. This is longer than 10 seconds, okay? But it's going to cost you. They want this data, the 2 Julians want our data for free. Hands up, should we give it to them? No, only 2 people put their hands up. They want to correlate it with heart rate variability and see, yeah, okay, you can. So 100 euros per... Yeah, and also 100 euros per cardiac cycle, okay? So we've got, I don't know, how many, that's at least 10 cardiac cycles there, right? I'm pretty good at this. So I think that's, a few thousand euros, just this section. But anyway, I'm showing you this. This is one of the first recordings, and I was actually still holding the microelectrode in the neck because it was such a beautiful recording, I didn't want to lose it. And so we're seeing these fluctuations in amplitude just with pulsation of the carotid artery. Nevertheless, we could follow the firing of the action potentials, and we can see that its discharge, its peak discharge is about 15 hertz, and its peak discharge is during expiration. And its firing rate goes down during inspiration. What could it be?
Vegas, of course.
Yeah, of course, we're in the Vegas. What could it be?
Respiratory sinus arrhythmia.
Yeah. What do you think? Hands up who agrees. We are. I know.
What's wrong with you?
Anyway, so I think this is intriguing because, look, so here's heart rate. Its activity goes down during an increase in heart rate. Importantly, its firing rate goes up with a decrease in heart rate. So the most parsimonious explanation is that it is indeed a cardioinhibitory neuron supplying the right sinoatrial node. We also record, here's a myelinated axon. This firing rate was also tonically active. And it's firing, oh God, I should read it here. And we also think this was a cardioinhibitory neurons. We have a few actually. It's going to cost you a lot of money, but you've got a lot of money. What is with the beer here? The cups are so small. Last night at dinner, I wanted to have a...
Weizen.
Yeah, Hefeweizen or something, you know.
Big glasses, a litre.
Well, you should try the Kolsch. I thought, okay, I'll have a pint of Kolsch, thanks. 200 ml, beautiful, beautiful beer. Anyway, I digress. Anyway, so again, so this had cardiac rhythmicity, and based on its firing during baseline breathing and slow deep breathing, we inferred that it was a parasympathetic cardioinhibitory neuron supplying the SA node. We can see, importantly, so this is slow deep breathing. We can see its firing rate is, what's this? Oh, this is the R wave frequency. Its firing is maximal just after the peak of inspiration, okay? And it is inhibited during the rising phase, during inspiration. Here's a different one. Based on its firing, the fact that its modulation decreased during an inspiratory apnea when you're unloading the low-pressure baroreceptors, we inferred that this was a low-pressure baroreceptor afferent located in the right atrium. So now the project that we're looking at, we're going to be looking at different cardiovascular diseases, but we now have funding to look at vagal nerve stimulation, which we've heard about. As you know, this has been around since the 1990s. It was shown in the 1950s in cats that if you induce seizures, you can turn them off by electrically stimulating the vagus. I don't know what led them to that experiment. I can't remember. Probably a research assistant said, hey, guys, we should stimulate the vagus. Fantastic, what a great idea, yeah. So anyway, in Australia, it's only approved for epilepsy, drug-resistant epilepsy, not depression, but in the US and other countries, it's also used to treat depression. And in addition to epilepsy and depression, it's also been used to treat heart failure and gastrointestinal disorders. How it works is very poorly understood, right? So Ivan's work was fascinating, but we know that VNS, vagal nerve stimulation, will activate axons traveling up and axons traveling down. So we got this big grant from the NIH, which was an absolute lifesaver because at the end of last year, I was out of a job. I had no money. So this is fantastic. And basically, this grant was to try and understand what vagal nerve stimulation does to other systems in the body. So we have a team looking at the immune system, a team looking at heart rate variability. We're looking at muscle sympathetic nerve activity. And I also got an additional component, an ancillary project, which is to look at which nerve fibers VNS activates. So the aim here is we have participants with these VNS electrodes in. We can locate where they are with ultrasound, and then we put a microelectrode above them. We turn off the VNS, then turn it on at 1 hertz, slowly bring up the current and see which nerve fibers are activated. Which is basically what I just said. So this will help us to understand how VNS works because, as I said, we know from the polarity of the action potential, whether it's a myelinated axon or an unmyelinated axon. And the question is, so the maximum currents that these VNS devices can deliver is 3.5 milliamps. And really, I strongly doubt that that would be sufficient to activate C fibers with a cuff electrode. If you've got a microelectrode inside the nerve? Yes, but not with a cuff electrode, particularly given that the current will travel from the cathode to the anode along the course of the nerve, not across the nerve. We've just done 3 so far. This is, stimulus side effects. This is a recording from the vagus where, as you can see, there was no ongoing respiratory-related activity and there's no ongoing cardiac-related activity. It was silent in the absence of this stimulation. It's highly likely, we knew that we're inside the vagus, it's highly likely we're in a fascicle supplying the gut, which is not going to be changing its firing with respiration or with the cardiac cycle. So there's no activation of nerve fibers at 0.75 milliamps, and we took it up. Nor was there activation, I'm reading this here, let me do the radio voice. Nor was there activation of nerve fibers during VNS at 2 milliamps in this same fascicle. This first stimulation train did not evoke neural activity. So we gave stimulation with the patient's clinical settings here at 2 milliamps. So this was the first cycle and it did nothing. But the second cycle, intriguingly, generated this tonic activity. And if I expand the time base, we can see, this is a triphasic potential, so C fibers. What could this be? Well, if it was an afferent fiber, it would be activated during the very first train. Why should it not? It would be direct stimulation. The fact that it was only activated in the second train means that there was some build-up required, and that this, the most parsimonious explanation here, is that this is efferent activity. So we're not directly exciting afferent C fibers, but reflexly exciting efferent C fibers going to the gut. And it's hard because we can't measure anything in the gut other than the EGG, electrogastrogram. It'd be great to have nasopharyngeal tubes with balloons to record and to distend the stomach. But at the moment, we're just looking at the low-hanging fruit, which is respiratory-related and cardiac-related activity. So to conclude, for the first time now, we can interrogate the physiology of the vagus nerve in awake humans. It's well tolerated, and it allows us to penetrate the vagus nerve without penetrating the carotid artery. There should be a little asterisk there, and the small print is, well, Mr. Burns, we did penetrate the carotid artery 4 times. 4 times out of 50 recordings isn't too bad. There were no consequences. Because we lost track of the needle tip on ultrasound, and then we thought, pull it out of it. We asked the participant if they were fine. There was no evidence of extravasation. As I said, the hole it makes is tiny. So we think it's intrinsically safe. And as I said, thoroughly humane. Anyway, so this will allow us to look at sensory and motor axons supplying the heart and great vessels, and how parasympathetic efferents to these tissues control cardiac and respiratory function. And we can look at different pathophysiological states, so like postural orthostatic hypotension. So we do all these on a tilt table, we get a stable recording and then tilt them up. And so if we have someone with POTS, for instance, we'll be able to see the increase in heart rate and hopefully a withdrawal of vagal drive to the heart. And we could look at asthma. So I'd like to thank the funding bodies, in particular, the V for Vegas, not Vaughan T. Matteo, Ty, Leah, Michaela, and David. And I thank you for your attention. 3:38.
Questions for what?
Thank you very much for your fascinating talk.
Thank you.
Very brave study. And I'm wondering, regarding polarity, what is the rationale behind this? Potentially it's a difference in between intracellular and extracellular recordings, because myelinated fibers are thick so that you can punch in.
Exactly. So there's been modeling work and actual recordings from isolated axons. So if you use animal axons, if you use a micromanipulator to slowly approach the myelin sheath, you start to see positive going spikes. As you go through the myelin, it remains positive, but as you penetrate the axolemma and you're in intracellular, it's negative. And if you record from the node of Ranvier, you get large negative spikes. So basically, as you know, the C fiber is without myelin, so you're just seeing the pure action potentials, as it were. With myelinated fibers, given that most of the axon is myelinated, the probability of recording from the node of Ranvier is very low. We do occasionally do that, and then you see very large negative going spikes. But yeah, so the rationale is that myelinated fibers were recording positive going spikes, and yeah.
Thank you.
You're welcome.
Yeah. Thank you. Amazing as always.
Thank you.
Did you have the chance to measure in the apnea timers the nerve during the contraction of the diaphragm? Because they start to involuntarily I think the lymphatic nerve really hits, really starts to hitting what happens with the vagus.
Yeah, no, that's a very good question. I'm still analyzing the data. I came away with so much data. So yeah, we do see these because what they do, the divers, is they take a deep breath and they hyperventilate beforehand, and then they pack their lungs. They go. It's like, like Julian having a bong at a party.
Back in the days, maybe.
Sorry, Julian.
You don't know how true that is.
I know it. And so basically, yes, so you see that, and towards the end of the apnea, they're making these tiny inspiratory efforts, and you can see all that reflected in the vagal recording. I have to analyze it all. But yeah, sure, with recordings of muscle sympathetic nerve activity with an end expiratory apnea or a prolonged apnea, you do see massive bursts of sympathetic vasoconstrictor drive. So you'd imagine that if we were recording from cardioinhibitory neurons, they would have been well turned off at the beginning. Yeah. Thank you.
Ivan.
That was really nice. Maybe I missed, but in terms of differentiating the sensory and the efferent fibers, is there anything on the waveforms that can?
Not really. I mean, a myelinated axon is a myelinated axon, whether it's sensory or motor. So in peripheral nerves, we record from motor axons as well as Golgi tendon organ afferents and muscle spindle afferents. The spikes are identical. Yeah, so it's hard. It really comes down to behavioral interpretation. So yeah.
But you don't have a collection of recordings that you can say these were sensory, these were...
Well, not yet, but this is what we're trying to do. We're trying to catalog the vagus nerve. Yeah, exactly. But certainly doing single unit recordings will allow us to have a better understanding there. Yeah.
Have you thinking of going even more crazy, like to put another electrode through the stylet cavity?
Oh yeah, that's a great idea. So like in the chest.
No.
Oh yeah, okay, but that's actually where it.
It's very easy to see. Yeah, it's not fair like compared to now.
Yeah. So it's about the level of the hyoid, isn't it? The stellate ganglion. Yeah, actually, I didn't show it. We had this recording in this participant where we saw these really large cardiac lock bursts. It was like, psh, psh, psh. It was just like muscle sympathetic nerve activity. We tilted her up, and the activity increased with the increase in heart rate. And we actually reasoned that, well, we saw that we were inside the vagus nerve. We thought, well, actually, maybe we've gone a bit further. It's in the cervical sympathetic trunk, which is just behind, right?
Yeah, exactly.
And when I went to Minneapolis last April, they wanted me to do a little demo. I said, well, I can't do a demo because you haven't got ethics approval. He said, okay, we'll get a cadaver. You could do it on a cadaver. I said, yeah. Well, how are we going to do that? Because there's no pulsing carotid artery. Anyway, okay, I'll do it just to make them happy. And I used ultrasound. I could see the carotid artery and got in within like 5 minutes. And then they still didn't believe me. They got a surgeon who specializes in the neck to carefully dissect away all the tissues, and lo and behold, there was the frigging electrode in the frigging vagus nerve. And I thought, happy now? And he said, do the other side. And they got another surgeon in afterwards, and sure enough, the microelectrode was in the nerve. So the point you raise is important because we should be able to record from the cervical sympathetic trunk, and perhaps we have, or, as Julian pointed out, there are tyrosine hydroxylase containing neurons within the vagus nerve, so it may well be that we were still in the vagus nerve, but we just happened upon these sympathetic fibers, right? So, but yeah, I got a text from a colleague just shortly saying, hey, Vaughan, do you think you can record from the carotid sinus nerve? I mean, you can record from the vagus, you just go a bit high in the glossopharyngeal nerve. It's theoretically possible, but a bit tricky. But it would be, yeah.
Because it's kind of a long.
Yeah, true.
Easier compared to a nerve that is pumping with the artery. So, like from my aspect, I think the easier for stylic ganglia, and because it's like a chain, it has 3.
Yeah, sure. No, you're right. Absolutely right. It's actually hard to see on ultrasound, but we probably just haven't been looking. Thing is, one of the recordings we did in Croatia, because we mapped the course of the artery and the nerve to find the best site. And in one participant, the best site for insertion was fairly low down, and the microelectrode was angled quite obliquely downwards. And as I'm approaching the nerve, the participants got reported pins and needles in the index finger, the middle finger. I thought, oh, that's not the vagus. And switched to record mode and stroked the hand, and so it evidently penetrated a cord root, whatever, of the brachial plexus. So there's a lot in there. It's tiger country, really. But yeah, so we should be able to record from the stellate ganglion. Yeah, good point. Maybe I'll come back next year to the MANIAC Symposium.
Depends on the deal now for the data.
Yeah.
So, Vaughan, you mentioned a limitation is being not able to open the chest. Any idea of combining that with cardiac imaging?
Yeah, no. So in the grant, we do have, we got approval and funding to do cardiac imaging, right? So, and as I said, we're doing all these on the tilt table. So then we can. The idea would be to correlate heart dimensions in these patients, in the supine and the upright conditions. So, yeah.
More questions for Vaughan? All right, then, Vaughan, thank you again.
Thank you.